Hello, my name's Hamish Laing. I'm a professor in the School of Management at Swansea University, and I'm going to talk to you about prudent healthcare and value-based healthcare, two concepts that are becoming adopted around health systems globally. Health systems, as you know, are facing huge challenges, and this was before the recent global pandemic. We've seen an aging of the population, so with more older people, and importantly, fewer younger people as a proportion. And that means that we've got an aging workforce in healthcare, not just aging patients. And that is placing real stresses on the staffing of many health systems. The second is the rise of chronic disease. As you know, whereas we used to see people maybe with one chronic disease having a foreshortened life, now we see many people with multiple comorbidity living to a ripe old age. And that's a very positive thing, but it does create complexity of care, and complexity of care can create additional cost. The third is the information revolution. It used to be that just doctors knew about the condition a patient had and they would share some information with the patient. But now we have patients with wearables and apps and devices and diaries and the internet who are becoming better informed themselves, but also have information about their disease that they bring to the clinic to share with the clinician. And so doctors and other clinicians are really becoming interpreters of information rather than the owners of information. And that is quite an important change of power in the relationship. The blessing and curse of technology. There are some amazing technologies coming into healthcare, be that surgical devices, medicines, scanners, and even now gene therapies where you can cure people of genetic conditions. But whereas in any other industry, introducing innovation drives down the cost of care drives down the cost in healthcare, it tends to drive up the cost, and that's putting a lot of pressure on budgets. And then finally, patients are behaving differently. They're becoming a bit more like consumers rather than passive recipients of care. In general, that's a very positive thing, but it does change the relationship and require us to work differently. It also raises expectations, and that can put pressure on too. So all of those pressures have come together, and that is manifest, as you can see in this slide, for rising cost across nearly every country that reports it. So the first thing you can see on this slide is there's a huge variation in the amount of money spent per person, depending on which country you look at. And just to make the point, because people are spending more money doesn't mean they get better outcomes. And in fact, in the United States of America, by far the most expensive, in the states where they spend less per capita, they get better health outcomes than the ones where they spend most. And we can perhaps come back to that. But wherever you start, the expectation is that over the next 10 years, the proportion of the country's budget that has to be spent on health is going to rise inexorably unless something changes. And so across the world, people are looking at how that challenge is addressed. And there is a global campaign. It's got different names in different countries. It's quite commonly called the Choosing Wisely campaign. In Wales, it's called Prudent Healthcare. In some countries, it's called parsimonious healthcare. In Italy, it's called the slow medicine movement. But they're all about dealing with over-medicalization, a tendency for the health systems to take control from patients and to try and manage their whole health condition for them instead of empowering them to look after themselves and not doing things that are really not going to make any difference to their outcome. So there is this concept of over-medicalization, and people are trying to reduce that through these approaches. So as you can see on this slide, in Wales we have prudent healthcare. It's a philosophy that is owned by government and has been developed within Wales, but it's modelled very closely on those other examples. And prudent healthcare has 4 principles. The first is that the public and professionals should be equal partners through co-production. In other words, the doctor or clinician and the patient should, between them, create a plan of management for somebody's condition. Equal partners. So not I've got all the information and the patient has none, but sharing the information in a way that allows them to help reach a decision about what they would like done, about what matters to them. The second is we should care for those in greatest need first, and that may seem obvious, but in reality it isn't what happens. And for various reasons, sometimes people who have less care needs get prioritized over people with greater need. And part of that is we don't spend enough time identifying what people's needs are. The third is do only what is needed and do no harm. Well, the last one is, of course, fundamental to us all as clinicians. But do only what is needed is about not over-treating people. We do have a tendency to do the most complicated thing when sometimes something more simple would do. Sometimes a non-surgical treatment option instead of a surgical option, sometimes a social option instead of a medical option. And reduce inappropriate variation through evidence-based approaches. There will always be variation in healthcare, and there is warranted or appropriate variation, and that's fine. But we all know of examples of unwarranted variation, where you see huge variations in treatment approaches or cost when the outcomes are not any different. And then finally, underpinning all this is a principle, which is only do what only you can do. And what that means is that everybody should work at the top of their license. So if there is something that you do as a senior doctor that could be done by someone more junior, then let that happen. If there's something that could be done by a physiotherapist, as well as, if not better than, a doctor, then adopt that approach. And not only is that getting best value out of every member of the clinical team, but of course it's more rewarding for people who are perhaps more junior to get given greater responsibility and an opportunity to do something that is perhaps more interesting as well. So just a quick task. Over the next 3 minutes, I'd like you just to talk to your neighbour about something in your own practice where you feel that perhaps you could ask another member of the clinical team to do just as well, and perhaps an example of unwarranted variation in your service or your hospital that really does need to be tackled. Okay, so thanks very much for doing that. I hope you found some examples, because I'm sure there will be some in your service. I'd like now to talk about value-based healthcare. So value-based healthcare is another global concept, first described by an economist at Harvard Business School called Michael Porter. As you can see on this slide, he defines value as an equation, and that equation is the outcome that the personal patient gets divided by the cost of care. And this is an industrial concept. It's brought from industry and other sectors, but you can apply it in health. But if you apply it in health, importantly, as you can see with this slight nuanced version of the equation, it's outcomes that matter to patients divided by the cost of delivering those outcomes, or if you like, the cost of the pathway of care. So the total cost of the pathway and the outcomes, not that matter to the doctor or matter to the hospital or to the government, the outcomes that matter to the person receiving the care. Now, of course, patients do care about clinical outcomes. They care whether they live or die after cancer, but they care about many other things as well. And we've been very poor at either asking what those things are or measuring whether they've been met. And so as an example, we would tend to measure maybe the range of movement of a joint after the release of a contracture. Whereas for the patient, yes, that is important, but what really matters is, can they do something functionally? Can they get back to work? Can they pick up a glass? Can they look after their baby? So outcomes that matter to patients should be our focus as clinicians. So in Wales, as you can see, in a Healthier Wales, which is our long-term plan for health and care, value is written throughout it. It's one of the 4 aims: to increase the value achieved from funding of health and care through improvement, innovation, the use of best practice, and elimination of waste. And I'm sure none of us would disagree with that. And then there are 10 design principles for the future health system. And one of them is about achieving better outcomes and a better experience for people at reduced cost, care and treatment which is designed to achieve what matters and which is delivered by the right person at the right time with less variation and harm. So when Michael Porter was looking at value, he realized that one of the reasons why healthcare didn't do value is we didn't really measure very many outcomes. And so he separately set up an organization called ICHOM, the International Consortium of Health Outcome Measurement. And they've been working globally for many years to build data sets of outcome of the things that matter to patients. And they've done that working with patients, with clinicians around the world, drawn from many different professions. So a typical outcome data set, and these are all available on their website at ichom.org, would comprise patient-reported outcomes, so things that quality of life measures and symptoms trackers from patients, clinical measures, the sort of thing we're familiar with, and then a little bit about resource utilization as well. So if I just give you this example, here is the outcome data set for hypertension, and it's specifically been developed for low and middle income countries. And you will see that there are measures of patient experience and quality of life. There are some issues about behaviors and literacy, health literacy, and then health status, the state of their disease, how well is their blood pressure controlled, have they had heart attack or stroke as complications, and what is their health-related quality of life index. And behind each of these is a full data dictionary. And that should allow people to at least understand the outcomes. And then if you measure the cost, you can start to consider the value of a particular intervention. So what about burns? Well, they haven't done one for burns. And I think that's a huge gap. And I've been pressurizing them into trying to develop an outcome set for burns. And I hope some of you in this room might be part of it if that comes about. But people have looked at patient-reported outcomes in burns, but mostly in a research context. And they tend to be quite complicated measures that are fine to administer in research, but quite hard to capture in routine practice. So there is work to do in burns, I think. But getting to a focus of outcomes that matter to patients is really critical. If you do have a measure of value, then as you can see from this example, which has got nothing to do with burns, it's about prostate cancer treatment. But here are 3 different treatments for prostate cancer and some things that matter to patients as measures. So sexual function, urinary continence, urinary bother, bowel bother, and vitality. That's a sort of sense of overall quality of life. And cost. And you'll see that of these three treatments, you've got brachytherapy, which is cheap radiotherapy relatively. You've got prostatectomy, surgical removal of the prostate, and you've got proton beam therapy, expensive radiotherapy. And you'll see that there is a huge variation in cost, but surprisingly little variation in the outcomes that patients say matter to them, except for sexual function. And so if you have a man for whom sexual function is still important, then you might want to consider if it would be good value for them to have proton beam therapy, which has the best outcomes for that. But if they are of an age where that is no longer important, then why would you suggest a very expensive treatment when all the other outcomes are the same for a cheaper treatment? Okay, so now time for your second task, and you've got 3 minutes. Please again talk to your neighbour and consider whether in your service you are delivering the highest value that you could. Or do you think that there might be interventions and treatments that you provide that may not be meeting the needs of patients as well as you could if you were to adopt a different approach? Okay, so thank you very much for doing that. And hopefully that's got you thinking. I want to leave you with just one other aspect of this. For value-based healthcare to be implemented in your health system, it needs to cover everything, not just the treatments. It needs to consider also the goods that you buy, the devices, the surgical instruments, and the medicines that you buy. So this concept of value-based procurement. And there is a lot of work going on about that. But it's really about placing clinical and patient-reported outcomes at the heart of procurement decisions. So in other words, instead of just buying the cheapest surgical glove or buying the cheapest device, considering whether you might enter into a contract with your provider that they receive payment on the basis of it meeting the outcomes that you all agree should be delivered. And if they meet those outcomes, they get the full pay. If they don't meet all the outcomes, they may have a less remuneration. If they exceed the outcomes, maybe they can earn more. So this idea of partnering with industry is another new concept that I would ask you to consider. And the medical devices industry have done a lot of work on this, and they've identified some key success factors, and Medtronic have probably led the way. So partnership and trust between industry and the health system, shared accountability for delivering the outcome, so it's not all just down to the clinician, it's a joint accountability, but you have to measure outcome at every stage. You can deliver greater value through innovation and create new business models and payment systems, as I've alluded to, that align financial incentives to delivering value and better outcomes. And most importantly, stop doing things that add no value. Thank you very much.